about her, but Dr. Chansey is actually the medical officer and epidemiologist with responsibility for the New World Screwworm, for sharing that kind of information with us. She's part of the Domestic Task Force lead for the New World Screwworm Preparedness and Response. We also have from PANAFTOSA, Dr. Baldomero Molina Flores, and he's a specialist in diagnosis, surveillance, and control of zoonotic diseases. Of course, we also want to welcome our local presenters, Dr. Celestina Petch, who is the Deputy Director of Animal Health at PAHO, and Ms. Mara Fernandez, who is the Surveillance Officer in the Epidemiology Unit at the Ministry of Health and Wellness. And you'll hear a little bit more about these persons as they are introduced. So we do have some solid presentations for you by persons who are well capable of delivering these presentations. And so I just want to thank everyone again for your participation and wish for you a very successful webinar. Thank you.
Thank you for those remarks, Dr. Bell. I hand it over now to Dr. Lara Friesen, medical officer within the Maternal and Child Health Unit and our current acting director, deputy director of health services. Dr. Friesen, I will ask you to make opening remarks on behalf of the ministry. Thank you.
Thank you so much, Mr. Kim, and thank you, Dr. Lewis Bell, for those remarks. It is my pleasure to give all of you the welcome today to this online seminar on the clinical management of the New World Screwworm, strengthening human and animal health response through a One Health approach. With the One Health approach, we recognize that health and disease in humans is closely linked to the health of our pets, farm animals, wild animals, plants, and the environment in which all of us live, survive, and thrive. In Belize, under the One Health initiative, we have collaboration between the Ministry of Health and Wellness, the Ministry of Agriculture, Food Security and Enterprise, the Department of the Environment, and the Belize Agricultural Health Authority, or BAHA. This allows us to closely collaborate and maintain a multi-sectoral approach to threats to human health, such as the emergence of infectious diseases, antimicrobial resistance, food safety, all the while we are promoting human health and animal health and environmental integrity at the same time. Now, the New World Screwworm was considered eradicated from Belize since around 1995. At that time, there was intense efforts to control this insect through the sterile insect technique, and there was an effort to push them as far south as possible. Unfortunately, in 2023 and 2024, after more than 20 years of eradication, the cases started to rise in Central America, and Belize reported its first case in animals in December of 2024. The New World Screwworm is not only an animal health crisis, it affects livelihoods, food security, wildlife conservation, and public health. And these infestations can devastate the health of livestock and wild animals. At the same time, they impose heavy economic and social costs, especially on our rural communities. In addition, they also affect human health. In Belize, the first human case of New World Screwworm infection was reported in August of 2025. So these are all the reasons why our approach must be integrated, coordinated. Today, we bring together experts from different areas, human health, animal health, and environmental health, to look at the regional and national situation and learn about clinical management in human cases. We will only be successful against the New World Screwworm if we come all together and work on this together, from international and regional organizations, some of which have collaborated with us for the session today, to our national line ministries, our whole health system, the agricultural industry, and local communities and farmers. So I look forward to a productive seminar as we learn more about the concrete steps needed to protect animal and human health. And to the speakers, thank you so much for your time, your expertise, and your dedication for coming on here today. And to the participants, thank you as well for your attention and interest to this session. So thank you again and welcome.
Okay, thank you, Dr. Friesen. So, participants, just a reminder that within the chat, we shared the link to a Google form for you guys to register your participation. As I had stated earlier, this will assist us in ensuring that your names are spelled correctly on the certificate of participation, which I'm sure you will need to collect the CME credit through the BMDA. It is still not too late to share the meeting link with colleagues since we haven't gotten into the main part of our presentation as yet. So grateful if you could share that via WhatsApp. They could log in on their mobile devices as well. At this time, we will move over to our first presenter, Dr. Aldomero Molina Flores, who is a specialist in diagnosis, surveillance, and control of zoonotic diseases within the Pan American Center for Foot and Mouth Disease and Veterinary Public Health. Dr. Molina Flores is a veterinarian with more than 25 years of professional experience in Europe, Africa, Asia, the Middle East, and the Americas with international organizations, corporations, and development agencies and non-governmental organizations. He is a visiting professor in postgraduate courses, training programs, and congresses, as well as an author of several relevant technical publications. Since 2015, he has been working for PANAFTOSA, where he is currently the focal point for New World Screwworm. Dr. Molina Flores, I hand it over to you.
Thank you, Dr. Bautista. Just need 1 minute. Let's see. Okay, I'm gonna share my screen. Okay, you can see my screen, right?
Yes, we can.
Yeah, okay. Thank you very much. Well, good afternoon to everybody. Hope everything will be okay because we are facing some weather problems. It's a rainy season here in Brazil, where I am based. And sometimes we have some problems with internet connection. Well, I don't think I need to introduce myself anymore. I will introduce to you today a regional perspective of the new world screwworm in humans. I'm sure that all of you know the Pan American Health Organization, PAHO, whose headquarters is established in Washington, D.C., in the United States, since 1902. So this means 124 years protecting people's health in the region of the Americas, specifically in 48 member states and territories, and specifically as well, more than 1,000 million people. But probably not many of you heard about PANAFTOSA. PANAFTOSA is the Pan American Health Center for Foot and Mouth Disease and Veterinary Public Health. Is one of the last two centers of PAHO. It was created in 1951 and it is located in Rio de Janeiro. However, provides technical cooperation to all countries, member countries within the region of the Americas. We have 3 technical areas: foot and mouth disease, zoonosis, and food safety, and 2 cross-cutting areas: epidemiology and laboratories. It is important to say that since 2014, PANAFTOSA has been a World Organization for Animal Health, WOHA collaborating center in veterinary public health. And the zoonosis unit where I work is particularly involved in the surveillance, prevention, and control of zoonotic diseases. I would like also to highlight the PAHO One Health policy established, agreed by member countries in September 2021 with 6 different strategic lines of actions. And why I would like to highlight this policy, because today the work that PAHO is doing is always under the framework of the One Health policy. This is particularly important for New World Screwworm, since it is a zoonosis affecting different countries within the region of the Americas. There are different names for this myiasis. In Spanish, for instance, is known as gusanera, querecera, bichera. In English, of course, screwworm or New World Screwworm. In Portuguese, it is known as bicheira. In French, Lucili boucher. Even in native languages such as Guarani, the New World Screwworm is well known, and it has also a specific name, Haso. The distribution of this disease covers the region between the latitude 30 degrees north and 30 degrees south, as you can see here in the map. Therefore, this disease is endemic in South America, except for Chile, and also in some Caribbean countries. Unfortunately, as we all know, it has returned to Mesoamerica. The presence of New World Screwworm, unfortunately, represents also a barrier to animal trade and is a risk to those countries that are free of this disease. Here you can see some graph from the World Animal Health Information System of WOHA, the World Organization for Animal Health, showing reported animal cases of New World Screwworms between 25. And here we can see that countries such as Costa Rica and Nicaragua were the countries that reported most cases of New World Screwworms in animals, followed by Mexico, but also Panama. We have some cases in Guatemala, Honduras, and even Belize is here with 196 animal cases. And in the second graph, we can see that since the first semester of 2022, the number of reported cases of New World Screwworms in animals increased, reaching a peak in July, December of 2024, and slowly decreasing in 2025. From a One Health approach, the New World Screwworm is considered a serious animal, public, and environmental health problem because affects livestock, but also pets, humans, especially those populations socioeconomically vulnerable, and also wildlife. And this can be a problem, particularly for those endangered species. We know that climate change, it would help to spread the disease into temperate regions, increasing the risk of invasion of New World Screwworm into currently disease-free areas. We could say that New World Screwworm as a disease contribute to poverty, to malnutrition, to social and economic instability in those countries and territories affected by the disease. And this is important from the point of view of the United Nations Sustainable Development Goals and the Agenda 2030. But the economic impacts of this disease in Mesoamerica have been calculated, and the estimate says that exceeds $550 million US per year, related to sport, to livestock production losses, but also to prevention, treatment, surveillance costs, and of course, to animal mortality. It is important also to highlight that in endemic country, New World Screwworm is frequently and severely affecting humans, particularly, as we already mentioned, vulnerable populations. However, the incidence of this disease is unknown. This is due to underdiagnosis and underreporting of cases, because for humans in most countries, reporting is not mandatory. It is also important to highlight the stigma that this disease means for people, which makes that some patients may not seek for medical care. Even if this is a disease, outpatient disease, in some countries such as Colombia, New World Screwworm myiasis is considered an intra-hospital important disease, which demand space, beds in the hospitals, and also time. The physician lack of familiarity with diagnosis, for example, in some countries, it have been reported as New World Screwworm cases of Dermatobia hominis. We will see later on about this other myiasis. And also, it is a problem, the lack of standardized treatment protocols. Here you can see some news from online papers reporting cases in Mexico, in Honduras, the first case of Belize, also in Panama, in Nicaragua, and the first imported case in humans in the United States. But as I mentioned before, the disease is also affecting South American countries. Here we can see an article, a clinical article from Peru, another one from Ecuador, another one from Chile. However, this was an imported case from Brazil. And as I said, sometimes human cases of Dermatobia hominis is diagnosed as New World Screwworm. Dermatobia hominis, also known as human botfly in English, or torsalo, particularly in the region of Central America, is a parasitic fly affecting livestock and human in Central and South America. And here you can see a very quick video showing how we can differentiate Dermatobia hominis from New World Screwworm, because the larvae of this parasitic fly needs to breathe and needs to, and if we close the skill entrance of the larvae, the parasite will try to get out. Okay. And let's talk about integrated surveillance and communication of New World Screwworms. Well, in the past, we thought that the Darien buffer will protect Central America and North America actually from New World Screwworm, because it was a natural buffer for people, for humans. But nowadays, this is not anymore the same. In fact, we can see that a lot of people is crossing through the Darien region to other Central American countries, that illegal cattle trafficking could be one of the reasons of the resurgence of the New World Screwworm in Central America. And sometimes we see that also people come with their own pets, like this news that we can see from a family from Venezuela. That's why integrated surveillance is very important. From the livestock animal health point of view, this is an example of an app developed by COPEC, which is the Commission for New World Screwworm for Central America. They have developed an app where farmers and veterinarians and the general public can report about New World Screwworm cases in livestock. This is another app that, even if it's not being used in Central America or Mesoamerica, it is used in Brazil and other countries of South America to report sick wildlife, and could be perfectly adapted to New World screwworm as well. And this is another example for public health surveillance that was developed and used during the COVID-19 pandemic, specifically to report cases in indigenous and rural communities where there is not doctor or where there is not a vet, and could be also easily adapted to the New World screwworm outbreaks in humans. Communication, as I said, is also very important. Here we have some leaflets, some basic information from different countries. In the middle, we can see Mexico. For the general public on how to prevent the New World screwworm myiasis, what are the symptoms, etc., etc. And another integrated communication example, this one from your neighbor Mexico, where New World screwworm is taken by different institutions from the environmental, animal, and public health, and even the academia, from a public health, animal health, and environmental health perspective. What have been done in PAHO, particularly regarding New World screwworm? Well, first of all, we upgrade the information about this myiasis in our website. Unfortunately, the information is in Spanish, but we could easily translate it to English if you find it is a need. And where we have updated some documents regarding New World screwworm infectations in humans. We have also produced some communication material to use in social media, as you can see here. And we are working with other international agencies working in the region of the Americas through the global framework for the progressive control of transboundary animal diseases. This is a FAO and WOHA initiative around the world, but here in the region of the Americas, other international regional organizations working with animal and public health are also involved, such as OIRSA, ICA, COPEC, the International Atomic Energy Agency, and in the case of PAHO, PANAFTOSA is representing the organization within this group. The group has established an expert panel of technical experts, allow me the redundancy, for New World screwworms, and we are participating in meetings and coordinating actions. As an example, we can present here the webinar that was organized, regional and national for Mexico, webinar that was organized by ICA, and PAHO through PANAFTOSA was invited to participate in order to provide a public health perspective of this disease. But there is also engagement with other stakeholders, such as the CDC and the FDA. And I would like to take the opportunity to thank the CDC because they have been always very supporting with us and with the countries of the Americas. As an example, I could mention the workshop we organized in Costa Rica in 2024 with the participation of the CDC as well. I can mention also a virtual seminar we organized in Panama with the support of the PAHO representation, and also the generation of information such as these preliminary reports on protocols, guidelines, and clinical evidence for the management of a screwworm in Mexico and Central America, which very soon, I hope, we are going to publish in the Pan American Health Organization journal. And finally, we have also provided review and update of guidelines and protocols for the surveillance and clinical management and prevention of newborn screwworms in Honduras, in Costa Rica, and also, most recently, in Belize. So that's all from my side. Thank you very much. This is my email in case you have any question, in case you would like to have access to the information I previously mentioned. Thank you very much. Over to you.
Excellent. Thank you, Dr. Molina Flores. We will immediately move on to Dr. Salustino Pech for a local perspective and update in terms of the local animal situation with New World Screwworm. Dr. Salustino Pech is the Deputy Technical Director of Animal Health at the Belize Agricultural Health Authority. Dr. Pech is a veterinarian. At PAHO, he specializes in surveillance of transboundary diseases and safeguards national animal health. Dr. Pech has served as the focal point for Belize's screwworm response and continues to oversee outbreak management and national data reporting. Good afternoon to you, Dr. Pech, and I hand it over to you.
Good afternoon, Kim. Thank you very much. As Kim was saying, basically this is just an overview of what is the situation here in Belize with New World Screwworm. As you can see, the total amount of cases currently is 899 reported cases. Among those, canines is the one that predominates. We have 54.95% of the cases, which is 494 of canines. Bovine, we have 188. For porcines, we have 94. Equines, 53. Ovines, 42. Caprines, 9. We have cases in wildlife as well, particularly howler monkeys. We've had confirmation on 4 howler monkeys. Felines, cats, we have 4 cases. We have 4 confirmed human cases, and I can say as well that today we confirm another case in humans. So probably Myra will speak more about that. We have in avian as well. We have 3 cases. Here it was a turkey, a chicken, and an egret. 2 cases in rabbits, squirrel, 1, and as well on a tapir. The district that has the more reported cases is the Toledo district, followed by the Cayo district, and then as well Orange Rock. As you can see, we have cases all over Belize. For last week, we have only 4 notifications. This is a problem that has been going on for, let's say, all in the region. All the countries have been reporting that people are no longer reporting their cases. So that is a challenge that all the countries in the region are having. This is the cumulative map. As you can see, it's basically all over Belize. So here in Belize, it's endemic now. We're living with it. Something to mention as well is that regional efforts are trying to harmonize surveillance and as well mobilization of animals so that everyone is under the same protocols. But this is the overview for Belize up to week 06, which was last week. If you guys have any questions, then I'm available.
Excellent, short and right to the point, Dr. Pech. Thank you. So what we'll do now is we'll move along, since there is a segment for question and answers towards the end. We'll move into the presentation in terms of the experience with the local human cases that we have managed. And this will be presented by Ms. Myra Fernandez, our surveillance officer within the epidemiology unit at the Ministry of Health. Ms. Myra has over 20 years experience in public health and surveillance and expertise in epidemiological monitoring, capacity building, and health system strengthening. She is committed to advancing data-driven decision-making through effective surveillance, training, and cross-sector collaboration. Ms. Fernandez is currently serving as the National Surveillance Officer and National Coordinator for the Field Epidemiology Training Program, FETP, here in Belize, and plays a key role in program development, mentorship, and strategic implementation. Mrs. Fernandez, I hand it over to you.
Good afternoon. Please let me know when you can view the PowerPoint.
We can see.
Can you see my notes or can you only see the slide?
Follow the slide.
Okay, good afternoon again, everyone.
Good
Thank you
afternoon.
for taking the time and for joining. I hope that the information that we share with you will be of utmost use, and because I'll need you to also be part of the surveillance as it relates to New World Screwworm. Let me know if the slide is changing.
It is.
Okay. So we know that the New World Screwworm is a parasitic fly, and it is of considerable zoonotic and economic significance in the Americas, because it is known for its ability to infest and to consume the living tissue of warm-blooded animals, including humans. So we know that in humans, infestation leads to painful progressive wounds as larvae burrow into tissue, often accompanied by secondary bacterial infections, fever, and systematic illness if it is not treated promptly. So within the One Health context, the NWS exemplifies the need for a coordinated effort across medical, veterinary, and environmental sectors. Its presence then underscores the critical importance of integrated surveillance and coordinated response. Between 1988 and 1994, Belize was part of the regional eradication effort that was successful in eliminating the pest. The regional eradication program was led by the US and Mexico, which used the sterile male flies to break the reproductive cycle of the screwworm. Belize then maintained its screwworm-free status until the recent reemergence in 2024 with the suspected reported case in Toledo that was later confirmed. So for context, the Ministry of Health developed a guideline for surveillance and treatment of NWS in humans, and this was developed in 2025 prior to our first case of NWS that was reported. So as it relates to our case definitions, we look at a One Health approach. A suspected or probable case is defined as any individual presenting with a wound infested by live maggots with signs of deep tissue involvement and lives in or have a history of recent travel to an area with known transmission. So then a confirmed case is someone confirmed by laboratory confirmation. A discarded case is a suspected case whose lab diagnosis results in a negative test. As it relates to case detection and notification, suspected cases identified in public or private facilities with a diagnosis on clinical findings should be reported within 24 hours to the nearest healthcare facility, as well then reported to the EP unit, to PAHO, and the local public health. The larvae specimens are collected and submitted to either public health or vector for transfer to PAHO within 24 hours, and the sample submission form must be completed and delivered to BAHA. The surveillance teams then subsequently submit an investigation. An investigation report is done along with the case investigation form, and all cases are entered into the BHIS using the respective code. Following the confirmation of the case, the response is needed from the surveillance focal points or the surveillance team in the local areas or the respective areas, and this should be initiated within 24 hours of notification of the suspected or confirmed case. The team investigation should be a joint investigation as where it is possible. So the recommendation is for a 6 to 12 miles house sweeps, interviewing residents and looking for ulcers or wounds or skin lesions indicative of myiasis in animals and humans with the assistance of BAHA or the Ministry of Agriculture where possible. The inspection of domestic and live animals should also be done, along with the inspection of environmental conditions with the public health inspector, who should then give recommendations and conduct subsequent follow-ups as needed. Additionally, community sensitization should be done. The follow-up protocol indicates daily monitoring of the case until closure, guided by the patient's clinical evolution and a re-examination of that patient after 15 days. It could either be done by telephone check-ins, home visits, or video call. And the surveillance should be maintained for up to 30 days after the last case was detected in that specific area. So for 2025, between Epi week 1 to 53, we saw 2 cases in Epi week 33 alone. Our first case was detected on August 30th, data onset August 13th, and then August 14th. Epi week 42 with a data onset of October 14th, and Epi week 47 with a date of onset November 20th. When we look at the cases by area, we're seeing all cases really in the Cayo district. So the first case was in Benqueviejo, our second case in Camalote, the third in Bolitri, and the fourth was in Belmopan. No deaths were reported. Here we can see the distribution of the cases on the map for the Cayo district alone. When you look at the cases by age group, we see one person being affected, age group 20 to 29, one 30 to 39, one 40 to 49, and the last case was a 60-year-old. When we look at the first case is a patient reporting a lesion for like over 4 months. During the first month after noticing, he sought a natural treatment from a local healer. And then about 6 weeks later, he began the treatment with glucantime, which was purchased from Guatemala, Melchor area, which he received 4 doses and observed some improvement. And then that prompted him to discontinue the medication prematurely. So when that lesion worsened, now he reverted to natural remedies, and then he eventually sought hospital care after experiencing a tingling sensation and a very escalating pain on his leg, which then became very severe and he could barely stand. So we can see the signs and symptoms that he had, which was very severe. His data onset was August 13th. When it comes to his medical history, he does have a history of a drug addiction. He did presented difficulty breathing, and he was also diagnosed with leishmania and then later confirmed with leishmania and consequently HIV. So here is a picture of that lesion. So the lesion was located on his lower left calf. It measured approximately 6 inches by 3 inches. So it was reported that about 40 larvae in the second instar and 1 larvae in the third instar stage were extracted from the wound. So the patient took a long time to cure, but he was basically cured for both NWS and Leishmania. When we look at the description for the second case, this case was from Kamalote. He's a 60-year-old. The patient had previously sustained an ankle injury from an accident he had in June 2025, which he did not seek medical intervention and was still bleeding occasionally. So he discovered the larvae in the wound on the 14th of August, and then he immediately went to the hospital where he got hospitalized. So there was daily larva extraction from the wound, and confirmation was not asserted until the 19th of August after the notification was delivered from the nurse. So the patient was in the hospital for some days before notification was given to local public health. He reports not having any engagement in field work. Upon inspection of his premises, it was noted that there was no availability for sewage waste disposal. He lives in an open yard, has several animals, and he also lives alone. The patient was also recovered. Patient number 3, or case number 3, is a 31-year-old male from Bully Tree Falls in the Cayo district, and he visited the hospital for treatment of a head wound, an injury that he sustained during a fight or a bar fight in the same area. He was hit behind the head with a battle. The wound was cleaned and he was released, and then the patient stated that he started feeling a biting or tingling sensation behind his head, and then he went back to the hospital on the 14th of October where it was reopened and the sample was collected and it was confirmed for screwworm. The patient resides in Bully Tree. He basically has no known specific address or does not have a stable home. He has no partner, basically is alone. He has a known history of alcohol use, smoking, and occasionally smokes other things other than cigarette. And at the time of he being interviewed by the team, he was still to some extent intoxicated. And so it is, he reported that he is a mechanic and that he lives in an area where he basically is just a handyman or a yardman for some residents in the area. And he takes care of animals there, and to his knowledge, no animals were sick. Case number 4 was a 40-year-old person. This patient was admitted at the hospital on November 22nd. The patient is hypertensive. He had a progressively developing cyst mass that was located at the back of his head that was first documented in 2023. He was discharged from the hospital November 27th. He has been doing well. He has recovered from that. And there are also environmental concerns when investigation was done at the household. And they also reported poor solid and liquid waste management. So recommendations moving forward. Belize still maintains a low level sporadic cases as it relates to human cases, with no evidence of outbreaks because all the cases were 1-1 cases with some type of social demographic factor involved. And of course, the public health awareness, the targeted intervention happened for each case as per the guidelines. And PAHO has always been part of what is going on in the area. So I would say from our end that we have a very good response as it relates to NWS for the country. So presently they're collecting data on the case investigation form, but the plan moving forward is to basically be able to capture that data using good data. And just to mention that Belize does have a One Health committee, and NWS was one of the diseases listed under the prioritization list when Belize held that meeting back in 2024, when they had the One Health zoonotic disease prioritization process done. Belize has done that, and NWS was one of the diseases listed on there with the objectives to prioritize zoonotic diseases of greatest concern for the country, and then of course trying to see how we can collaborate as partners. With that, I leave you. Thank you.
Okay, thank you, Mrs. Fernandez. And now we move into our main presentation. That will be done by Dr. Rebecca Chansey, who is a medical officer and epidemiologist, and the domestic task force lead for New World Screwworm Preparedness and Response. She is from the U.S. Centers for Disease Control and Prevention, CDC. Dr. Chansey is a medical officer within the parasitic disease branch at the CDC, where she focuses on parasitic diseases and emerging zoonotic threats. She has authored numerous journal articles and book chapters and has been an invited speaker at national and international conferences to educate others on parasitic diseases. She is currently working to raise awareness of the resurgence of the New World Screwworm and its risks to human and animal health. Dr. Chansey, I pass it over to you for your presentation. Thank you.
Yes, thank you so much for the invitation to be here. Let me share my screen and you can hopefully tell me if you can see it or not. Okay, can you see it in presentation mode?
We are seeing it, but I think we are seeing the next slide as well.
Okay, what about this one?
Yes, better.
Okay, perfect. Thank you so much. So I'm happy to be here today to discuss clinical management of human cases. As you know, and the reason that we're here is there's an ongoing outbreak of New World Screwworm myiasis in Mexico and Central America, including, as you said, in Belize. And New World Screwworm does represent a serious threat to both animal and human health, not only because it causes painful invasive infestations that can lead to severe tissue damage and secondary infections and potentially death, but it leads to economic losses in livestock production, it impacts animals, and it can increase public health burdens in the infected communities. Movement of humans or animals that are infested with New World Screwworm can transport New World Screwworm into new areas where flies are not currently present. And so we consider travelers to be in this group as well, which could increase the public health burden and risk of infestations of both animals and humans in new communities. So New World Screwworm, as you know, is a fly that causes myiasis. It's one of the rare flies that feeds on living tissues, and it primarily affects animals, but humans can also be infested. And so in the region, we're seeing more animal cases than human cases, but the human cases are also important. And the myiasis, as I said, it causes extensive tissue destruction, can be fatal, and requires prompt identification, reporting, and treatment. The life cycle is important to know because there's two areas where we try to intervene to halt the life cycle. The female flies of the New World Screwworm only mate once, and they mate with wild-type male flies who mate more than once. And once the mating happens, the females lay eggs, and the eggs hatch within 24 hours. And these eggs are laid in any warm-blooded animal, which could be, cattle, other animals, or humans. And the larvae that come from these eggs remain in the body for up to 7 days, feeding on the living tissue, and then they drop into the ground. Once the larvae are in the ground, they become a pupae, they develop into their next stage, and they emerge as an adult fly after a period of time. So the ways that we are trying to interrupt this life cycle, sterile flies are being released at the northernmost edge of the outbreak, and the sterile flies mate with the wild type flies, and if the wild type female meets a sterile male, then no eggs will be produced and therefore no larvae will be produced. So that's one way to interrupt the life cycle. The other way to interrupt the life cycle is to extract all the larvae from the animal or the human, kill all of the larvae, and not allow them to drop onto the ground and pupate. And so that's where we need your help and your assistance as clinicians to make sure that you identify these patients, identify the larvae, remove and extract and kill all of the larvae to prevent the progression of the life cycle. So in humans, New World screwworm myiasis the flies can lay eggs in wounds as small as a tick bite. It can be, something that's imperceptible to the person, but there's an opening in the skin and the fly is able to find it and lay the eggs. Any area of the body can be infested, and we're going to talk about some of those areas in case reports a little bit later. We've seen a lot of infestations in the scalp, and I think people, forget to wear a hat. They forget that there might be a scratch on their head, and so the flies find that area. But even beyond just a skin opening, the mucous membranes and the body openings are also areas where the fly can lay eggs. So that could be the ears or the eyes or the nose or the mouth. Even the genitals and the anorectal area can be infested. And so this picture is of a woman in Honduras. There was a news report recently, and she had an infestation in her nasal area and sinuses. And you can see they're trying to get some of those larvae out by irrigation techniques. The symptoms of New World screwworm in people will vary based on the location of infestation, but in general, these are very painful wounds because the larvae are eating living, healthy tissue. If you have a larva that's a facultative myiasis eating dead tissue, it may be less painful, but because this is healthy tissue, it's quite painful. There's a sensation of movement of the larva, and then there's foul smelling. These wounds are quite foul smelling, and I'm told that the odor is very unique, and once you've smelled it, you won't forget it. And then there may or may not be bloody discharge from these wounds. There's often extensive tissue invasion and destruction, but depending on how the wound is located and where the wound is located, you may not actually realize how deep the destruction is. On the surface, it may look fairly superficial, but it can go quite deep and invade, quite far down into the body area. The larvae move in and out of the wound, and so you may see some larvae around the open sores. And then because these larvae are passing through the skin, they're passing through, mucous membrane areas, they carry the bacteria with them. And so oftentimes they create secondary bacterial infections that need to be treated with antibiotics. And so people may present for the first time, not only with a skin wound, but also with fevers, chills, signs of sepsis. And these are the things that are severe and can also lead to potential mortality. So death may occur due to the secondary bacterial infections or because of the degree of tissue destruction in the patient. And you can see this case report from a patient who had a scalp wound and what it looked like on the bottom, and then once they opened it up, where the larvae were seen. So some of the risk factors for New World screwworm infestations in people: anyone who is outside doing various outdoor activities where the flies are circulating are at risk for getting infested. That may be people who are working around infested livestock or around other animals. If they're, for some reason, they're sleeping outside, especially during the day. People who don't have an ability to protect themselves from flies and insect bites. So I hear some of your cases, we're consuming alcohol or we're consuming drugs. So they potentially may not have had the ability to protect themselves from flies. And then if they have open wounds or medical conditions that compromise the skin, such as eczema or psoriasis, or a break in the skin from falling and a wound. And then if they're elderly or incapacitated and they're not able to seek immediate care, they don't have their wounds addressed properly, they're also at risk. So in your patient population, if you have a patient who is coming to you and they have some concerns and the symptoms sound similar to New World screwworm, you should have a heightened awareness of thinking of New World screwworm on the differential if they've been in an area where New World screwworm is endemic or re-emerging, which for your setting would be Belize. And then if they are complaining of painful lesions, if there's this movement inside the lesion, if there's a malodorous bloody discharge. and then if you see larvae and if you see extensive tissue destruction. So this patient on this picture returned from Costa Rica to Canada, and he fell in Costa Rica, and then in Canada they detected that the wound, instead of being just superficial, was quite deep, and there were larvae inside that were New World screwworm. New World screwworm is diagnosed by removing the larva and submitting the larva for identification. Because there are other types of fly larvae that may infest the wounds that are not New World screwworm, it's really important to have these larvae identified, to send them all off to your health authorities and labs to make sure that you know which myiasis your patient has. As Dr. Baldomero mentioned, the differential diagnosis does include furuncular myiasis, and furuncular myiasis is usually caused by Dermatomia hominis, the human botfly in Central and South America. And in this instance, these botflies lay eggs on blood-sucking arthropods like mosquitoes. And when the mosquito takes a blood meal, then the larvae penetrate the intact skin, which is different than the New World screwworm larva penetrating a wound in the skin. And typically with Dermatopia hominis, you have only one or a few lesions. It's not, a large area with potentially lots of destruction. And the infestation only remains in the subdermal space. The patient may still complain of itching and pain and sensation of movement, but it's going to be different from the New World screwworm symptoms. And even though there is a difference in the larva, it's important to send everything to your healthcare authorities so that they can correctly do the morphologic examination and correctly identify it. The picture here on the right shows the size difference and shows the shape difference of the Dermatopia hominis on the left and the New World screwworm on the right. And you can see that the screwworm looks like a screw and the Dermatopia hominis is quite big and thick. So that can also help you have a greater idea of which one is infesting your patient. Another differential diagnosis to keep in mind is facultative myiasis. So as I mentioned, these are the flies that lay eggs typically on decaying matter. So whether that's decaying matter in the environment or some kind of dead tissue in a human, it's not going to be living tissue typically. And so it's going to be an unclean wound, a necrotic wound, and it typically affects people who are bedridden or unable to prevent, protect, or clean their sores and wounds. The common housefly is one example. There are other examples depending on your setting, but those larvae as well may also morphologically resemble New World screwworm larvae, and so it's really important to send off that larva for identification. So some of the key features that New World screwworm larvae have that other larvae do not, as I said, they have a screw-like shape that tapers anteriorly and then truncates posteriorly. They have these encircling bands of pointed spines on each body segment, as well as these really dark tracheal trunks that lead from the posterior area of the New World screwworm. And then the very end is called a posterior spiracle, and it has these little two buttons that are not fully enclosed, but have a little bit of an opening. And so these three pictures represent some of the key morphologic characteristics of New World screwworm. So how do we recommend New World screwworm treatment in patients? We recommend that all patients with suspected New World screwworm infestation should see a healthcare provider immediately. We've seen that delay in accessing care leads to worsening outcomes for not only the patient, but also potential spread of the New World screwworm. And so we want people to seek care immediately. And then once they do present to care, it's really important that all larvae are physically removed. There are some circumstances that we have been made aware of where the patient went to one provider, one or two larvae were removed, and then they went back again and more larvae were still present. So we recommend re-examining any lesion after 24 to 48 hours to confirm that none of the larvae are remaining and that every single larva has been accounted for and removed from the lesion. Debriding the necrotic tissue will help to ensure healing of the wound. And making sure that the patient has proper wound care, until the wound is healed is really important, because you can get infestation. If the wound is not healing, it's still an open wound for a New World screwworm fly to be attracted to. So the wound care must be adequate to heal the wound. This will be painful for the patient, so providing them the appropriate pain management until the wound is healed. And then, as I said, the antibiotics are really important to treat secondary bacterial infections. And the kind of antibiotic that you prescribe, whether it's an antibiotic against gram-positive or gram-negative bacteria, may differ based on where the infestation is located in the patient. And again, we'll go through a couple examples, but as you would treat any other patient who has a wound in a certain area of the body, those antibiotics would be also used to treat the infestation in that area of the body. Or if you have a culture, obviously that helps to identify which bacteria may be present. And then removal and proper disposal of the larva will help prevent the spread of New World screwworm into a new area. The use of ivermectin has come up many times, the question, and there's no clinical studies of ivermectin for New World screwworm infestation, but we're aware of many case reports of off-label ivermectin use as a supplement to attempted removal of the larva. And so it would be up to your clinical judgment whether or not that's something that, if your country protocol includes it, or if you feel like it might be beneficial for the patient. But from our standpoint, we're telling people that there's no clinical studies to show the actual use of it. Handling of New World screwworm larvae is really important because we do not want any live larvae to be discarded in the trash or on the ground, again, because we're trying to prevent the progression of the life cycle to the adult fly. So when you see a patient and you're removing the larva, it's really important to wear gloves and use forceps, and then collect all of the larvae and place them in a leak-proof container with 70% ethanol. Then submerge the larva in a volume of 70% ethanol sufficient to, cover all of the larvae, submerge them, and this will not only kill them, but also preserve them for a confirmatory diagnostic exam. And if for some reason you don't have the 70% or greater, or 70% ethanol, you can use 70% or greater isopropyl alcohol or 5 to 10% formalin, and then send these to your appropriate health laboratory so that you can receive morphologic identification. As one of the other presenters mentioned, the reporting of both animal and human cases is really, really important. This should be considered an urgent public health event. And so you should not delay in identifying the patient, treating the patient, and reporting the infestation. The public health authority should be notified immediately, and the animal health authority should be notified immediately. And the public health and animal health authorities should communicate together across the One Health spectrum about any suspect and confirmed cases so that the public health response and the overall response can be coordinated. So how can people protect themselves from New World screwworm? We do want people to keep their skin wounds clean and covered and make sure that the wounds are healing well. Limit exposed skin if possible by wearing loose-fitting long sleeve shirts and long pants, socks, or hats. And then by using insect repellents, ideally one containing DEET, you can hopefully prevent some of the tick bites or mosquito bites or other bites that may allow New World screwworm to lay eggs. And then you can treat clothing and gear with permethrin, definitely sleep indoors or in rooms with screens. So now we'll move on to some case studies. There are no human cases of New World screwworm in the US. And so the cases that I'm going to present are either travelers who have returned to the US or other countries, or they are case reports from other countries. But the reason that that there's interest in understanding the clinical considerations for New World screwworm in humans is because, as I said before, a delay in treatment can lead to not only health complications for the patient, but an infestation can occur in various places of the body, and so it may be something that is not immediately recognized, and there's a high degree of vigilance that's needed, and appropriate treatment of the patient and the handling of the larva is important to prevent further progression to the adult fly. So this is a case report of a patient who has a New World screwworm infestation in Mexico. It was just recently published last month. It's a 12-year-old female from Chiapas who was previously healthy.
Sorry,
She-
Dr. Chansey, the
Yes.
slide isn't advancing to the case.
Uh-oh. Okay. Can you see it now?
No,
Not yet.
we're still on the slide on how people can protect themselves from New World screwworm with the insect repellent. We're still on that slide.
Yeah, I think she's freeze, right?
Yes, Dr. Chansey, I think you're frozen. Colleagues, let's just bear with her for a couple seconds to see if she will get back in. Colleagues, our apologies. I'm not sure what is happening with Dr. Chansey and her connection. I just sent a request for her to rejoin. But I'm not sure. She seems to be offline, so I'm not sure if it's an issue with her connection. In the meantime, colleagues, if you have questions, maybe you can just jot them down so that when we get to the question and answer session, or I'm not sure if Baldomero, if you want to try and answer any questions at this point that may come up, especially as it relates to animals or the situation in the region. I think Ms. Fernandez and Dr. Petch may still be on, so if there are any questions for them, Mr. Bautista, maybe we could take those in the interim.
Yes, sure, I'm available for any questions.
I'm here.
Yeah.
Actually, I forgot to mention about the fifth case that was just confirmed today. Just for a little background, the team is presently on the ground doing the field investigation. But what we have so far is the patient is hospitalized. He is a 64-year-old male with a date of onset February 17th, and he has a history of a left ankle injury and a right leg amputation secondary to an RTI that happened basically quite some years ago. And he basically resides in the outskirts of San Victor in Corozal. He does report cattle grazing frequently on his property. No other cases or suspected cases have been reported since then, and the team is basically ongoing with the investigation. Thank you.
Mr. Bautista, maybe you could field some other questions if there are for any of the
Yes.
others.
Yeah, colleagues, if you are unable to open your mics to ask questions, you could post them in the chat, and I will read them out and address them to the appropriate presenter.
Guys, don't be shy. We're here for you.
I'm so sorry. Can you guys hear me now?
Yeah,
Yes.
Okay, I have no idea what happened. Let me try to share my screen again. I apologize for the technical difficulties.
No problem. Thank
No
you for
worries.
rejoining.
Okay, let's see here. Share. And okay, do you see it now? Can you see
Yes,
it?
we do. Yes, we do.
Okay,
Yes.
okay, thank you so much. Okay, yes, and this is where I left off, right? The 12-year-old girl who was, this is a case report from Mexico, and she had reported that a fly entered her left nostril. She was at school, and she initially experienced some rhinorrhea and nasal itching. She was fine for the next couple of days, but then developed pain in her left maxilla that radiated to her left nostril, and she started developing a cough with green sputum, and they started to see larvae coming out of her nose. So they took her to the local community hospital where they removed some of the larvae. The case report didn't say how many larvae were removed. And then she continued to have pain a few days later in her left ear and a headache. And so then she went to a different hospital that was specializing in pediatrics, and she was evaluated by multiple different teams of doctors. When she arrived, she had age-appropriate vitals, she was awake and alert, but they did see these larvae in her left nostril. You can see the picture here on the slide. She had runny nose from both sides, and then they noticed a pharyngeal abscess in her oral cavity as well. They did confirm the larvae were New World screwworm, and when they cultured the wound, they found Pseudomonas in her wound, and her other lab results showed mild anemia and some inflammatory markers. So they did a CT scan of the paranasal sinuses, and they found agenesis of the frontal sinus, some thickening of the mucosa in both maxillary sinuses, some inflammatory changes consistent with ethmoid maxillary sinusitis of the left nasal cavity, but then they found bilateral anterior ostomeatal complex obstruction, septal deviation, left palatine tonsil hypertrophy, and a hypodense collection in the left parapharyngeal region. She received initially some clindamycin and cefotaxime for the left parapharyngeal abscess, as well as ivermectin for the myiasis. But once they cultured the Pseudomonas in the wound, they were able to switch her to cefepime for 10 days. ENT did an endoscopic surgical treatment using functional endoscopic sinus surgery, where they debrided the nasal cavity. She required excision of the anterior ethmoid bone as well as the ethmoid bulla on the right side, revealing purulent materials in the right maxillary sinus, and no purulent materials were identified in the left side. And then she had surgical drainage required of the deep neck left parapharyngeal abscess. Ultimately, after all of this treatment, she was discharged and doing well. The next case report is of a Brazilian woman who had New World screwworm in her vaginal area. She was 87 years old. She was a gravida 13, para 13 of low economic status, living in a rural area, and hospitalized for 1 week of pain and intense vaginal pruritus. And when they did the exam, they saw a cystocele, a rectocele, poor hygiene, and large numbers of larvae in her vaginal cavity. So after removing the larvae and giving antisepsis of the vaginal region, washing and encouraging her to use underwear at home, she was able to go home and recover. This particular patient in Brazil had a rare case of digital myiasis. It was a 41-year-old woman who had a history of psychiatric disorders, and she lived in an abusive home in poor social conditions. And so she wasn't able to seek care after she got a knife injury to her second finger of her left hand. And during this time of not seeking care, obviously the wound worsened, and the neighbors ultimately took her to care 6 months after the initial wound. And the exam showed a large area of finger necrosis, as well as amputation of the finger and cellulitis. And as I said previously, typically facultative myiasis happens in the necrotic areas, but there were still some living tissues, some healthy tissues, underneath, deep down, and that's where they found the New World screwworm larva in some healthy tissue that was drilled out in pocket-like holes under the skin. And ultimately, she required extensive surgical resection, and they removed 132 larvae from this area. This patient in Honduras, there was a case report last August that was reported, and the patient had anorectal myiasis caused by New World screwworm. He was a 55-year-old septic tank worker from a rural northern community. He had hyperglycemia and type 2 diabetes, perianal pain, discharge, and prolapsed hemorrhoids. And when they examined him under anesthesia, they saw numerous larvae invaded the anal mucosa and second and third degree hemorrhoids. And they ultimately did a submucosal hemorrhoidectomy with larval extraction. He required antibiotics, wound care, control of his diabetes, and he received a dose of ivermectin. There's a case series that was published several years ago now that was looking at different head and neck cases of myiasis in the literature at that time. And what I want to call your attention to is, again, the locations of the lesions can be anywhere. And a lot of these patients had head and neck infestations, or they had infestations in the retroauricular area, the orbital region, the palate, the submandibular region. And the sequela was quite intense. There was bone and soft tissue loss, there was hearing loss, there was blindness, there was difficulty on communication, there was salivary gland loss. So it's so important to identify these cases soon, treat them appropriately quickly, so that you can minimize the sequela for these patients. So I'm going to highlight a few of the travel-associated cases, and as I mentioned, the delays in diagnosis can lead to not only poor outcomes for the traveler, but also if the larvae are not handled appropriately, they could support establishment of the fly in a new area where the New World screwworm is not yet present. And travelers don't typically pass through inspection points that may be present for animals. So this is a map that one of my colleagues made about published instances of New World screwworm introduction through travel. You can see the endemic areas in South America and then the current outbreak areas in Central America. And the arrows show where the infestations were acquired and then where the traveler brought the New World screwworm infestation back to when they returned to a different country. So it's definitely something to consider when people are moving around the world. There was a patient, so again, looking at different areas where myiasis can occur and New World screwworm infestation can occur in the body. This patient in the UK presented with myiasis in his scrotum after vacationing in Venezuela. He had 3 sinuses in the scrotal area, he had a subcutaneous cavity, and there were 40 larvae that were removed and identified as New World screwworm. This patient had a New World screwworm myiasis in his arm after going to Brazil and doing adventure racing. He was 41 years old. He was racing in the jungle. He tripped and fell at night and had a wound on his arm. And then they removed the gravel and the dirt, but they also removed some insects from the wound. But he continued racing for the next several days. He rebandaged the wound a couple times, but it obviously never healed. And then when he returned back to Germany, they found the larva and removed it and confirmed that it was New World screwworm. In the US, there was a patient a few years ago who traveled to Colombia. She was a 12-year-old female and had a scalp wound that she also had scalp psoriasis and was scratching it quite regularly. And so there were a lot of excoriations in her scalp. And when she was in Colombia and they identified scalp pain, she went to a clinic, she received empiric antibiotics, gentamicin and cephalexin, and then due to the escalating pain, when she got back to the US, they went to a physician, identified 10 different scalp ulcers that had this oozing, foul-smelling yellowish exudate, and they found 142 larvae in these different wounds on her scalp. And as I mentioned earlier, in Canada, there was a patient who went to Costa Rica, got a wound, went back to Canada, and he was found to have 30 larvae in that wound. So in general, the messages that I want to highlight are that New World screwworm infestations can occur anywhere in the body, any wound site, any mucous membrane site, and a high degree of vigilance is needed for detection of these patients, treatment of these wounds, and identification of the larva. A delay in treatment can lead to health complications for these patients, and they can be very, of varying severity, including ultimately sepsis or death if they're not treated. And then prompt reporting is critical to the response to ensure appropriate surveillance and control measures are in place. And as some of the other presenters mentioned, the One Health coordination is vital to ensure that public health and animal health authorities are communicating well about suspect and confirmed cases so that the prevention, preparedness, and response activities can continue. These are some of the resources that we have put together through our CDC websites, through some of the other recording and webinars that we've done. And then there's the screwworm.gov website that has a lot of the USDA information on it as well. So thank you very much. Sorry for the technical difficulties again, but I'm happy to answer questions.
Yes, thank you, Doc. And thank you, colleagues, for majority of our participants have remained online, and now we would want to engage you guys a little bit in terms of this question and answer segment. And so while you guys put together your questions, I have placed in the chat a Google Drive link to the current New World Screwworm Treatment Guidelines that was developed by the ministry last year, and that can be downloaded. Just a reminder that for those who have registered on the Google form, we have your email addresses, and we will also be sending the presentations to you guys as well. And so with that, I would want to open the floor at this time for questions and comments as well.
Colleagues, you can either raise your hands or open your mic and speak.
I had one question to kick us off, if that's okay, for the presenter from Belize. I just wanted to confirm the first case that you presented had an active ongoing leishmaniasis infection, and that's where the New World screwworm flies were being laid. Is that correct? Or the eggs were being laid? What were they, was there a treatment given for the leishmaniasis as well?
Can you hear me?
Yes.
Yeah, the ministry does have something in place. We do surveillance for leishmaniasis. And so when the investigation was conducted, with a separate investigation was done for leishmaniasis, and then one for New World screwworm, and then consequently the team that deals with HIV basically also had to do their investigation and follow up on their end. So there were 3 things that were done, and for the leishmaniasis, it was resolved as well.
Thank you.
Yeah, I think I would want to add a comment at this time as well. Typically, what we have seen, and as Ms. Fernandez has indicated, 4 of the 5 cases are from the Cayo district. We've had the Western Health Region, Belmopan catchment area, and the San Ignacio Community Hospital catchment area managing cases. And now, Dr. Chansey, as you were offline, Ms. Myra mentioned about a fifth case that was detected in the north today that they're currently responding to. And so one of the things that we tend to see is the first question is, what do we do? Who do we contact? And typically, we have the public health and vector control offices located at all the compounds of the regional hospitals. And so these are typically the first persons that we would reach out to after samples have been collected by the clinician as per protocol. These are then handed over to the nearest BAHA office, where those are confirmed by the BAHA entomologists. Thereafter, then the regional management teams, members of the surveillance teams, would then coordinate along with other stakeholders, such as BAHA, for the field investigation. So typically, for the identification process, you would then collaborate with the public health department, who would then facilitate the handing over of samples of larvae over to BAHA for diagnosis, for identification, sorry. And then, of course, currently, as we have shown in the previous cases that we discussed, we made a decision that we will be using ivermectin for treatment, and those are what that is what we have been treating the previous cases with. We have placed ivermectin since last year at each of the regional hospital pharmacies, and so that is something that I believe Dr. Murray, our Deputy Director of Hospital Services, have also informed from last year his various chief of staff across the country, and so they are aware in terms of the availability of these medications. So I just wanted to send out that reminder to the team. In terms of those from the private sector, I think we could, if there is any consultation that is required in terms of management of the cases, or even access to medication, they could always reach out to us, and we will facilitate as well. So as I said earlier, we within the chat, we have the Google Drive link to the current clinical management guidelines.
Thank you. And can I just ask a follow-up question? If the patient receives the ivermectin, they still seek out medical care and have the larva removed from the wound as well?
Hi, Myra, would you want to speak on that a little bit?
Sure. As well as the medical follow-up that needs to happen. So it's not as if they can buy something over the counter to say they would treat themselves. So they need to access a health facility for that to be given to them and administered properly, as well as the dosage. Can you hear me?
Yeah, it was breaking up a little bit, Myra.
Yeah. Do you want me to repeat?
Yes, please.
Yeah, what I was saying is that for all the cases that we have had, they all need, it is not something that is given to them over the counter. So it has to be under medical supervision that this happens. So this is all outlined in the protocol that Mr. Kim was talking about.
Yes, thank you. But in addition to the receiving of the ivermectin, the larvae are also removed, right?
Yes, and so this has to be done under medical supervision. So it's not something that they will do on their own.
Okay, thank you.
So are there any more questions for our presenters? Any comments? Okay, Dr. Bell, it seems either we muddy up all the everything, or the presentations were very clear. But either way, it's been a long afternoon. We didn't go too much over estimated time slot.
Good afternoon.
Yes, go ahead.
I have a question.
Sure.
What, I don't know if maybe the question is directed directly to Ms. Rebecca Chansey that was speaking just a while ago, or maybe it's related to someone else. I can answer the question. How frequently, or what's the percentage of misdiagnosis of the worm?
Well,
In
there's
other
a
words,
couple.
saying it's Screwworm and it's not.
Right. So there's a couple variables at play. I mean, one of my concerns, well, one of the reasons I wanted to make sure that the larvae were extracted and sent for identification, you know, if the patient is treated but nobody sees the larvae and nobody receives them in the lab to identify them, then we don't know if it's screwworm or not. We just know the patient had myiasis. And then if the larvae are not preserved correctly and they're destroyed as opposed to put in the ethanol to preserve it, then the identification will also not be able to happen. And then if the larvae are sent to a lab where the people are not experts at identifying it, they may misidentify it as something else. So there's various steps along the process where it's really important to make sure that the larvae are all extracted, all preserved, all sent to a lab where they can be identified. But it's true, you know, if the patient takes the larvae out themselves, if the larvae are not preserved correctly, there could be cases that are not reported to the Ministry of Health and therefore missed. Does that answer your question? We don't have a denominator because we don't know how many of those cases are happening.
I was more concerned, or I'm more referring to the patients that we actually identify, we actually hospitalize, and we actually have we garner the worm. All of that process goes. And that's what I'm asking. How likely or least likely is it that we make a wrong diagnosis of the worm?
I'll defer to Ms. Fernandez to see what your laboratory is like. I know in our setting in the US, the CDC is requesting all larval samples to be sent to us. We do it by telediagnosis if possible, but we are the reference lab for the country. So in the setting of Belize, it sounds like you have one reference lab, but I'm not sure if there are others who are also able to diagnose it.
If I may, from the presentations that were made this afternoon, first of all, I think the presentations were very clear, so I want to thank all the presenters. And I think one of the biggest takeaways from this presentation is the importance of extracting all of the larvae, preserving them in alcohol, in ethanol or alcohol or formalin. And from my understanding, the requirement from the guidelines of the Ministry of Health in Belize is that these should be sent to PAHO for identification. And I do believe PAHO has enough expertise and capacity to adequately identify. So from the participants here, I think this has helped a lot in the sensitization, in enhancing the awareness to ensure that any future cases that may come to the attention of the health facilities, that efforts would be made to ensure that all of the larvae are extracted and sent to PAHO under the conditions that have been outlined for the proper identification. We may not be able to say what may have gone before, but it is my hope that with this information that was shared today, that going forward, should we have additional cases in both animals and humans, then that we will be able to ensure the adequate diagnosis of the New World Screwworm.
Yeah, excellent, Dr. Bell. I think that that while Dr. Petch, I believe, has logged off at this time, I know that PAHO has also built some capacity in the districts, so as not to overburden the sole entomologists that they have up in Central Farm. One of the things that indeed we have seen other myiasis cases that were not caused by the New World Screwworm, not many, but at least a few. And then, of course, there are times when there may be some misdiagnosis in terms of the traditional bot fly or bee form, as they call it locally. But as Dr. Bell mentioned, the key thing is to be on the safe side is to extract larvae samples for confirmation. I know that PAHO has asked that we submit at least a minimum of 10, 5 to 10 larvae, as many as possible, at least 10. In the guideline that I put in the chat, or at least the link to the guideline, there is a form that accompanies the sample as well. And of course, that our public health officers could support that process as well in terms of completing that form, along with other members of the surveillance team. And that form basically identifies the source of the sample. And of course, PAHO will utilize that same form for to document whether they confirm it is indeed the New World Screwworm larvae that the samples that they're looking at.
Can you hear me?
Yes, Myra, go ahead.
Yeah, I think Dr. Is it Dr. Rivera was asking the question? Yeah, just to add to what you have already mentioned, I think it's very hard for the clinician to miss a case. If probably missed initially, they would eventually look at the case because of one, they said the characteristics well, two, the oozing, and three, the patient will complain of the movement of animals of worms inside the womb. And thirdly, if we look at it, it has a life cycle that it has to complete. So it has to feed for a certain amount of time. And after that, it basically is going to fall out and drop on the ground. So you will eventually see something if it's not really working. But once you start medication, then you start see the animals also dying out. So, but the idea behind it is for them to remove all the worms from the wound. And just to go back to the first case that we had, the patient did had the issue with the leishmania. So when we did the test for leishmania, it was negative at first. But I said, you know what, you guys need to do this test again because we do know it is leishmania as well. So they literally had to go a little deeper to be able to do the testing, to do the reconfirmation of leishmania. Similarly, the patient had to be in the hospital for a while for the monitoring to ensure that the medication is working and to ensure that other things are also discarded because they also have the risk of other infections, as was mentioned. So then they would do other types of swabbing or testing because then it's not only that we'll be worried about, but other things that the patient can also be exposed to while in the hospital.
Excellent. Colleagues, do we have any additional questions or comments for the panelists before we close off? No. Dr. Bell, would you like to give some closing remarks, perhaps?
Thank you, Mr. Bautista. I think this was an excellent webinar. And clearly, this was one that is of interest to many people because we had so many participants join this webinar today. I want to really thank all the presenters and colleagues, just to share with you that Dr. Chansey is in the US. So, you know, this is beyond her working hours. And so I really want to thank her for spending the time outside of her working hours. The same applies to Dr. Molina Flores. He's in Brazil, and their time is about 3 hours ahead of us. So it's now almost nighttime for him. So I really want to thank them for agreeing to share their information with us. I think the presentations, all the presentations, Ms. Myra's presentation, Dr. Petch's presentation was to the point, very clear, and you know, we're able to share all the information that is of relevance. As I'd indicated before, you know, the take-home message is, what can we as clinicians or public health practitioners who are on this webinar, what can you do to enhance the diagnosis, management, and the prevention of additional cases? And more importantly, how can you share this information with others to ensure that the information is spread widely to those who need to know in terms of the role that public health plays in the prevention and control of the New World Screwworm? So I just want to thank everybody, and especially those who remained to the end. I think it was a very useful webinar. Thank you.
Okay, thank you, Doc. Thank you, colleagues, for logging on. And as I said earlier, we have your email addresses. We're going to be sending presentations as well as the copy of the current treatment guidelines. And of course, we'll be reaching out to you guys as well with your copies of your certificate of participation. So thank you guys for logging on this afternoon and staying with us. Have a good evening.
Thank you. Bye, everyone.
Thank you. Good evening for all.
Thank you. Bye, everyone.
Bye-bye.
Bye.